Hello. So today we're taking a step away from our spotlight series on mental health disorders, and we're going to speak on a very real issue within the field of mental health care, which also occurs in healthcare in general. So our presentation today is focused on the racial bias that occurs within mental health care, how implicit bias, racial disparities, and systemic racism persist to this day to really prevent underrepresented communities from receiving adequate care, especially affecting our Black and Indigenous communities as well as other people of color. So, when we speak of racial bias in healthcare, we often think of medical care pertaining to one's physical health. And we thought this history was still pertinent to preface our discussion today, so we'll introduce a few cases that acknowledge this history of racial bias within healthcare, some of which you may be familiar with. So, one of the first cases we'll talk about is that of Crownsville State Hospital. This was a psychiatric hospital in Crownsville, Maryland, established in 1911. And due to the discriminative segregation of the time, there was actually no hospital in Maryland for Black patients suffering from mental health disorders. So, this hospital was built supposedly with the intent of housing Black Americans with mental health disorders, but more often, homeless Black Americans and criminals were also sent here because mainstream society deemed them as unhealthy, even if they were not suffering from any mental disorders. And these Black Americans were subjected to painful experiments, research, and abuse, as well as just awful conditions due to overcrowding and understaffing. Employees of Crownsville actually testified that for many years the rate of death was greater than that of actual hospital discharge. And another case which you may have some exposure with is the U.S. Public Health Service syphilis study at Tuskegee. So syphilis was a large concern in the 1930s. It afflicted 1 in 10 Americans, and there was no treatment developed at the time. And in 1932, the USPHS actually worked with the Tuskegee Institute on a study to research treatments, but also to investigate whether the individual's race was a factor in the progression of this disease. So these researchers, they recruited Black men to participate in the study in exchange for free medical exams and free meals. And these participants were simply told they were being treated for quote unquote bad blood, and they were not properly informed of the true background of this study. In 1943, when penicillin was discovered to be the best treatment for syphilis, this information was actually kept from the participants as well, to the point that during World War II, the researchers actually spoke with the draft board to have these men be exempt from serving so that they could not be enlisted and even have the potential to access penicillin. This study, it plays a large role in what we know today in bioethics as the concept of informed consent, and this history of medical abuse against Black Americans contributes to the medical distrust that this community faces today. And while the two I just spoke on were some examples with very deep historical roots, here are a couple of examples of how the history of racial bias and systemic racism still persists in medicine today. So one statistic that has been brought to more public attention within the last few years is the stark difference in maternal mortality rates in Black, Indigenous, and Alaska Native women in comparison to white women. Black, Indigenous, and Alaska Native women are 2 to 3 times more likely to die from pregnancy-related causes than their white counterparts. And the social factors that contribute to this issue include that implicit bias that these communities experience every day, not just from regular citizens, but also from providers. A history of structural racism within medicine, and as well as the quality of healthcare they receive from providers who may harbor unconscious biases against patients of color. And in relation to this, many studies have worked to investigate and confirm the systematic undertreatment of Black Americans in regards to medical pain perception. So, one 2016 study by Hoffman et al. Actually found that a significant number of providers still assume and base treatments on false medical beliefs of racial differences and pain. And if you guys are curious about the statistic, I think it was about 40% of those that were surveyed. So that's really crazy. Examples of these false beliefs that are horrifically still endorsed by some medical professionals today include believing that black people have thicker skin, less sensitive nerve endings, and more coagulable blood than their white counterparts. So they're using these false beliefs to justify the treatment decisions they make for these patients. And often these treatment decisions are very different than the route they would take for a white patient. It is also much more likely for black Americans, as well as other people of color, to encounter providers who don't take their pain seriously, even if the provider doesn't endorse these false beliefs necessarily. And while the cases I just discussed are very significant to our understanding of systemic racism within healthcare, the focus of our presentation today is really how this racial bias persists in the framework of mental health. So I'll pass it on to Christine and Zoe to discuss the disparities, barriers, and stigma that communities of color face within mental health care.
Right, so like Ali said, we're going to be talking about that. And so the first thing I wanted to pose for you guys is a discussion question, and that is considering your experiences, what are some differences that we might see in mental health care for Black, Indigenous people of color and people of color? So shout them out or type them in the chat. So Wendy says, I'll just read it out. I recalled how pain perception of African American women was lower because slavery owners didn't want to spend money on giving medicine or doctors to ease their labor and birth pain. So it became a stereotype. Um, yeah, that is definitely a large issue. Um,
Yeah, if I can jump in, I would say kind of like how Ali was talking about that a lot of the scientific reasons that have been given for Black people having a larger pain threshold than white individuals, it's really kind of a pseudoscience, and it's rooted in a lot of structural racism. And obviously, you can see in that example, Wendy, that that's rooted in the history of slavery. And, studies have shown that that's really not true. And that the fact that slave owners didn't want to spend money on giving Black women pain medication, that doesn't, evolution doesn't work that fast. And that's really an excuse. Um, but it's definitely a great thing to bring up because it's just another one of those excuses that Ali was talking about that try to make racism into science.
Right. And I just want to highlight also that pain perception study was done in 2016, which is pretty recent. And the preconceived notion that we have that it's racial bias doesn't exist is obviously not true, given that it's so recent. And so, yeah, thank you for sharing, Wendy and Zoe. Um, yeah, lots of great ideas. Thank you guys for sharing. For the interest of time, we're gonna move on, but yeah, great ideas. We're gonna touch on some of these. So the first thing I'm going to talk about is the state of mental health care in America for Black, Indigenous, and people of color. And so when we think about Black, Indigenous people of color, these are typically our minority populations. And with that, that brings up the minority stress model, which means that those who are minority background will undergo more stress in their life as opposed to their white counterparts. And so the stress can look like socioeconomic stress, stress due to their race, um, stress due to their workplace bias, and things like that. And so One large problem is accessibility to these mental health care facilities. When we talk about minority populations, majority of them live in suburban areas and maybe rural areas, and as opposed to their white counterparts who live in more urban areas because of socioeconomic status. And so, one statistic that we found was that about 1.5 behavioral health providers were present for 10,000 Medicaid enrollees in rural populations, as compared to about 6.5 behavioral health providers per 10,000 Medicaid enrollees in urban populations. So, just to highlight that difference, geographically speaking, the accessibility is still a large problem there. Um, and there are different methods of accessibility that we'll touch on later as well. Another large problem is the lack of diversity in our mental health care. Um, Majority of mental health care providers are white individuals, and so with that, if you are a Black, Indigenous person of color, it is difficult for you to go to a mental health care facility and see a person who is like yourself, and have a provider sort of relate to you in terms of being a person of color or Black, Indigenous population. And so this is still a large problem for us. Lastly, there is a problem with funding of mental health care. Our funding has been pretty stagnant in terms of the mental health care, and that is a problem because there have been increasing demands for this mental health care. And so with increased demands and stagnant funding, this in turn increases disparities in mental health care, making mental health care really inaccessible. And so, um, because of this lack of funding, there becomes a large issue of these people not even receiving the care that they um, want to receive. And lastly, I'm going to talk about undocumented immigrants, who are another minority group in America that are typically not highlighted very much. And with the advent of the Trump administration, there was this notion of an anti immigrant rhetoric, which describes the idea that immigrants are lesser than other populations in America. And so, from that, for example, President Trump administered like an immigration policy. Additionally, he also encouraged for the Mexican and USA wall to be built. Things like that really exacerbate this negative stereotypes towards immigrants in America. And so this idea really brought about higher levels of stress and trauma and made people more vulnerable to these stress and traumas. Um, Especially these undocumented immigrants who are in America. And also, as a result of that, that causes a lot of mistrust and uh, medical distrust in terms of mental health care. And then that also evokes fear of seeking even mental health care for themselves, and then also having them live in a society of just isolation. So these are just really large problems that we face for BIPOC individuals for mental health care in America. And so this is just a graph that I found on NAMI, and it describes the use of mental health services among adults. And it was just interesting to me to see the percentages of each races. Um, as you can see, the white female percentage was 21.5. Oddly, the male one is 11.3. This was just really interesting to see the different percentages across the different races. So, yeah.
And just to plug, if we want to talk about gender differences, you can always go back
Right.
and watch our men and mental health presentation.
Yeah, right. And this graph shows the lack of diversity across the psychology workforce. Um, in terms of looking at the different races represented here, as you can see, the white bar is extremely different than the Asian, Black, and Hispanic and other column. So this describes the psychologists who are in academia or in mental health services, who are in research and such, or doctorate degrees. And so this is just to highlight that lack of diversity as well, again. And lastly, this is a graph showing the workforce availability in mental health. The key here is the number of providers given the ratio to the population. And so for a lighter color of purple, it's going to be 200 providers per individual, and then the darker colors is going to be 1,200 per individual. And so as you can see, areas that are like, for example, really dark purple like Texas, Louisiana, Mississippi, such Tennessee, these areas are areas that have pretty low availability of mental health care. And so that is due to the lack of workforce availability. And so, yeah, that is another accessibility thing that we touched on.
And we've been talking a little bit about these POC barriers to mental health care, but just to hone in on that a little bit, there are a couple larger issues. One is medical distrust. And there's a phenomenon called the dropout problem. And that's a phenomenon that people of color often see a healthcare provider for a health concern or issue for one appointment and then never return for follow up. Looking at causal factors for that, there's, quite a few. And not the least of that is issues with cost and insurance, and also of cultural competency and the idea of feeling respected and provided dignity and feeling that your provider understands your culture and the circumstances surrounding your visit. As well, there's also fear of public agency. So Christine was talking a bit about undocumented immigrants. Often undocumented immigrants do not have access to government health insurance and may not be able to access private health insurance. And there can be a fear that by going to a public agency like a public hospital, a fear of retribution and of, immigration services being called just for seeking very needed medical help, whether it be physical or mental health care. And of course, Christine was also talking about this lack of representation of people of color among healthcare providers. And that also contributes to medical distrust because, when you don't see someone that looks like you in a field like medicine, it can build distrust or at least prevent additional trust. And Ali talked a bit about provider bias in physical healthcare. That also exists in mental health care. Some studies that we read while researching this presentation showed that there is a decreased willingness of healthcare providers to provide and prescribe mental health medications to people of color. So just like we were talking about this idea of Black individuals being seen as having a higher pain tolerance than white individuals and being prescribed pain medication at a lower rate, people of color and especially Black and Indigenous individuals are being prescribed mental health medications at a lower rate for the same symptoms and same disorders. Additionally, there is a phenomenon of Black individuals being misdiagnosed and overdiagnosed with schizophrenia when they come in with the same symptoms as white individuals that get diagnosed with depression or bipolar disorder or OCD or a variety of other issues. And this can be attributed to provider bias in seeing psychotic and violent symptoms in Black individuals, and also this lack of cultural competence and not being willing or able to understand the differences that might arise just in that history of living as a Black individual or living and growing as a person of color compared to a white individual, and the differences that might manifest in your presentation. And another population that we really wanted to talk about was prison populations, which really ties into race because, as probably lots of us know, there's quite an overrepresentation of people of color in our prison populations, and especially our Black and African American population. So we talk a little bit about this idea of criminalization of people of color with mental illness. So people of color alone and people with mental illness alone are overrepresented in prison populations. Black individuals are represented at 5 times the rate of white individuals in prison populations, and people with mental illness are represented at twice the rate of those without. And obviously, those are also minority populations, so that makes that statistic even more stark. And when you combine those two, we get this issue of interdisciplinary and magnified effect. People of color with mental illness are even more so overrepresented compared to their representation in the general population. And that's probably even more significant because people of color have lower rates of diagnosis with mental illness compared to white individuals, both because they're not seeking out care and because of this provider bias that is not diagnosing them with mental illness, or at least providing them means to recover from mental illness. Additionally, access to mental health care in prison populations is severely limited. 63% of people with a history of mental illness do not receive treatment while incarcerated, and 75% of people who were receiving medication when they entered incarceration stop receiving mental health medication when they enter incarceration. So there's this lack of continuity of care, which can be really dangerous to a person, especially if there's a sudden stop of taking a mental health medication, just like any physical medication. That can be very dangerous. And it's also, just an issue of justice and of health. Additionally, I wanted to share this story of Doug Smith, who's the peer programs manager for NAMI in California. And I actually have spoken with him before. He has a great story. He presents for NAMI across the nation. He talks openly about his struggle with major depressive disorder and addiction, which ultimately ended up with him being sent to jail. But jail was the very first environment in which he was able to obtain medication for his depression. And then when he was transferred to prison, he was told that if he wanted to continue on this medication, he would have to be transferred to a maximum security facility where the prison hospital was. And he would probably end up being cellmates with a 200-pound sexual or violent offender. And his other option was to go to a minimum security facility and not receive any medication. And so he decided to do that. And he left prison after serving his time and ended up back in prison 3 months later because he wasn't able to receive this mental health care because he couldn't have this continuity of care, both within the prison system and, of course, as he exited prison and tried to reintegrate into society. And there's this idea of this trade-off between quality of care and prison security level, this having to decide between physical safety and mental health and the injustice in that. Additionally, unique to every population and every community of people of color, there are unique cultural stigmas. And we wanted to talk about a few. Obviously, this isn't all encompassing, but here are just a few examples. In Black communities, cultural stigmas associated with mental health, there's often an idea of turning to religious coping and praying it away rather than seeking physician help or medication. And mental health conditions are often seen as signs of personal weakness. In Latinx communities, there are often fears of labels such as nervios, which kind of dismisses certain mental illnesses like depression and anxiety as short term and not really needing treatment. It's just nervousness. You don't need to see a doctor, you're just going to get over it. Or versus locura, which is craziness. And the idea of something like schizophrenia or bipolar disorder or OCD and being seen as crazy and something that can't be cured. And there's also a pressure to keep mental health issues private. There's a similar phrase in Spanish to don't air your dirty laundry out in public. And that's really contributes to one of those cultural stigmas surrounding mental illness and mental health conditions. In the AAPI community, there's often this idea of losing face versus saving face, and the idea that having a mental health condition and being open about that could bring shame to you and your family, and you would lose face in uh, your greater community, or the people around you in your family would lose face along with you. And there's also this idea of the model minority myth and the societal and familial pressure that comes along with it to be perfect. And obviously, our society does not see mental illness and mental health issues and struggles as perfection. And so there's this idea of ignoring mental health conditions to conform with this pressure. In Indigenous communities, this is less of a cultural stigma and more of a cultural act um, or quirk that often Indigenous communities hold a fundamentally different understanding of mental health than Western culture, and often will not turn to Western medicine for help with mental health issues and mental illness, and will rather turn to spiritual treatment and traditional healing from their communities, which is not to say that that's any lesser than Western medicine, but it is a unique cultural factor to Indigenous communities that should be taken into account by Western medicine providers. And so, considering all those stigmas I just talked about, I know that was a lot of information. I wanted to ask you guys, how might a one size fits all approach to mental health care, which is something that is kind of the model right now in Western medicine, how might that affect different people of color?
There's different cultural stigmas, so it wouldn't fit them and it wouldn't fit others as well. So you can't just do a one size fits all because there's different beliefs and different things that you have to work with to make sure that the patient is comfortable. And a big part of mental health is the environment that a person is in. So if the hospital environment isn't good, then their mental health won't uh, get any better.
Right, that's super important that obviously someone's coming in there to try and improve their mental health. And if you already provide an environment that doesn't feel safe or comfortable for them, then you're gonna meet resistance right off the bat there. Thanks, Noah. Amy says ignores and dismisses the cultural diversity of people of color. Definitely. Yeah, like Noah was saying on this previous slide, we were talking about how different no two of those communities had the same stigma. Some of them were similar, but they had different origins and different uh, sides to the story, and they're unique to those communities. And like I said, those were not all encompassing lists, and it's so important to recognize that diversity and for providers to be able to provide care that acknowledges that diversity. Wendy says, I think it excludes people of color because the approach is based on white people and each culture is different. in how they perceive and cope with stress and mental health, such as for grief, each culture perceives it differently and there are different stressors specific to culture. I think that's, yeah, a great example with grief and definitely true. Um, and you said this approach is based on white people. That's definitely true for most of our medical model and definitely our medical model for mental health. Thank you, everyone, for your contributions. I think we'll keep on going.
Right, so that was a great lead in to talk about advocacy for Black, Indigenous people of color in mental health care. And so, ways you can advocate are to first educate yourself on differences in mental health care and risk factors for people of color. And also, these risk factors may look like socioeconomic stress, environmental trauma, adverse childhood experiences, and just higher exposure to racial discrimination and prejudice. Additionally, we want to avoid the stigmas and shaming that we see. And also, an important thing is to respect different levels of mental health acceptance, while also encouraging a higher level of acceptance, because in different cultures, there are definitely different levels, and that is something still work in progress and is done by our advocacy. Additionally, encourage younger generations to share their experiences and really fight the stigma of mental health care in Black, Indigenous, and people of color populations. And also, reaching out may be difficult, and speaking up about your mental health can be difficult. And so, it is important to check in on your loved ones and practice self care. And, like Zoe mentioned, mental health exhibits differently in varying individuals. And so, it is important to just look beyond those typical feelings that we think of mental health and consider other things that may be attribute to one's mental health. And lastly, we wanted to end with a note on finding culturally competent care. And so, as a Black Indigenous person of color, it is important to research providers who fit your cultural background. And if that isn't possible, take recommendations from trusted individuals such as friends and family. And so, this is important. Like I mentioned before, the lack of diversity really um, hurts the mental health care experience. And so, really finding someone who understands your background will make a more culturally competent care experience. Additionally, it's important to ask questions to providers, such as like, what is their background with working with uh, people of color, and also have they received people of color focused training for their profession? And if so, how do they approach the treatments differently when working with patients of different backgrounds? Additionally, it's also important to reflect after your healthcare visits um, and really reflect on how you feel and how if your needs were met and if there was effective communication between you and the provider, and if they treated you with respect and gave you the attention to your mental health care or to you in general, and also if they were open to being culturally competent with the treatment plans. um, just to give an example of that, people during the fast, and um, if the provider was, for example, against implementing some treatment that would allow the person to fast as well as also take medications at the same time, things like that would be an example of a non culturally competent uh, mental health care treatment plan. So things like that. And so, lastly, it is important to understand that as a person of color, Black individual, or Indigenous individual, you deserve an inclusive treatment plan for healthcare, regardless of the race, culture, religion, sexual orientation, etc., that you identify with. And lastly, see NAMI's person of color page on the links, and also on our next slides. We have resources for things that we used during our presentation, and also resources that we may find helpful for people of color, Black individuals, AAPI, and so on. So thank you for listening. We hope you learned something new today, and thanks for listening.